Let me know when you're ready.
It would have been really nice for someone to stumble over at least one word by this point. I'll break the ice. Yeah. So academic medicine is steeped in tradition and hierarchy and is notoriously difficult to change. I've been in this environment for about 20 years now, and I believe that the care of any patient is only going to be optimal if we have cohesive healthcare team functioning. It's not just about the doctor, it's not just about the nurse, it's not just about the therapist. It's about how they work together and how they coordinate and what they can then do for the patient. We've already heard this quote once this morning. I think that in healthcare, what I've observed is that people understand that other people matter, particularly when it comes to patients. Where they lack in this insight is when it comes to the other members of the healthcare team. Over the past 8 years, we've been working to try to create a more collaborative culture in the institution where I work. And despite all kinds of things, workshops, town hall meetings, appreciative inquiry summits, what we found is that our engagement scores now are essentially the same as they were 8 years ago. We hear comments like we're at our best when things are at their worst. So in crisis mode or in an emergency, people can come together and recognize one another's worth, rely on each other, and fully use their expertise. But in the day-to-day, that all falls apart, and those people who are heroes in crisis become obstacles or adversaries. And all that does is affect the care that we provide for the patient. So I wanted to figure out how to change this in the everyday. So last year, Asa Saarinen came and spoke to us, and he talked about microchanges, this idea that if you can make a subtle shift in the way that somebody is thinking over the long term, this can make a huge change. And so I kind of abandoned the idea of systemic change and started thinking about the individual. One intervention that we did was with medical and nursing students around the care of chronically ill children with chronic progressive illness. And our case was one of an 11-year-old boy who had Duchenne's muscular dystrophy and had become progressively weaker, and we were concerned that he might need to transition into a wheelchair. So we set up a simulated patient care conference where the medical and nursing students assumed the role of a primary care physician, a subspecialist, a healthcare system nurse, or a school nurse. And they came together with standardized patients discussing this topic and talking about how changing into a wheelchair would affect this child's life. Sometimes the nursing students played doctors and otherwise, so they got some new perspective. In addition to our normal evaluation, we asked these questions. What strengths did you see in one of your nursing colleagues, in one of your medical colleagues, and in this patient, and in his mother? And in so doing, in just refocusing people's attention, we heard amazing things. They found that their colleagues had poise and initiative and compassion and empathy and ingenuity, and that they were great advocates for this child. We don't have longitudinal data, but I'm hoping that these students will enter their practice with a different concept of what their colleagues bring to the bedside. Our second one was around quality and patient safety, and this was with interprofessional clinicians with whom I worked in the pediatric ICU. In this case, we started a room of errors where I staged a patient room and actually intentionally put 30 patient care errors or things that could significantly affect the care of the patient in the room. We had interprofessional teams go into the room and in 7 minutes try to figure out as many of these errors as they could. When they were in the room, they were in an interprofessional team, but they weren't allowed to speak to one another. They were to do this independently. Then they came out of the room, and together they created one collaborative list. And what we found in debriefing this is people were saying things like, I never even looked at that because I knew that you would. Or, now I realize how much I rely on all the other members of the team. And we surveyed a week later and found that people were incorporating what they'd learned into their practice, and that almost everyone felt that they had a better appreciation of the role of teamwork in assuring patient safety. So what I'm saying is that I think if we actually truly want to change the culture of medicine and healthcare, that we just need to help people see what they already know is there, but choose not to pay attention to. and that's how they feel about the people that work around them. A colleague of mine, Tony Suckman, said, you know, when the waves come up on the beach, they change the entire landscape by moving one piece of sand at a time. I'm now convinced that the way we'll change medicine is through micro changes. Thank you.
I'm really proud of Julie.
That's the best I've done it. I practiced 1,000,000 times and didn't do it well. I'm used to 20 slides in 60 minutes.
I know. What questions do you guys have for Julie? Yeah.
Yes.
Who's the microchange researcher?
Esa Saarinen. He's not a researcher, he's a philosopher in Finland. And he came and spoke to us in MAPP last year, and it was a revolutionary moment for me.
He was part of MAPP 600 last year. MAPP 600, I believe. Yes. Yeah. He's Amelia's PhD advisor, so they can put you in touch. Yeah. Jen. Oh, no, that wasn't them. What other questions? I'm a little curious about the room of errors. Yeah, but and so how do you reconcile the room of errors, which sounds very red cape, with a green cape or approach or positive psychology? Or how do you?
Well, I think the green cape moment is when people all of a sudden recognize how much they rely on one another. And also I think it's a green cape moment when you realize that you can walk into a room, identify something, and actually make a positive change in the care of that child.
Brilliant. Yeah, far back. Will you repeat the question?
So we were pretty open about the fact that we were emphasizing interprofessional teamwork in both of these, but I think the problem is that if you go in and you're only talking about interprofessional teamwork, people think that you're trying to do group therapy. In fact, people have said exactly that to me. And so I think that you have to couch it in the auspices of actually teaching something about content, either patient safety or something about a particular disease process, and then people become more open to it.
There was another question here, yeah. For those on the line, the comment was interprofessional collaboration is a really hard thing to be able to do, and this approach, making it fun, making it somatic, really takes it to the next level and makes it seem possible. So thank you.
Well, and that's why since MAPP, I've actually largely left my practice, and I'm now teaching in the School of Nursing.
Wow.
So.